Welcome back to The Explainer. Today, we're jumping right into a topic that, honestly, flies under the radar way too often in clinical practice. We're talking about the subtle, almost hidden ECG signs of right ventricular hypertrophy, or RVH. We're going to break down the anatomy, map out those electrical vectors, and figure out exactly what patterns we need to train our eyes to catch. Let's get into it.
So why is moderate RVH so incredibly hard to spot? Well, it's kind of a core medical mystery. The crazy thing is, moderate right ventricular hypertrophy might not alter an ECG much at all. I mean, it can literally hide right there in plain sight on your routine cardiac tests. You could have a patient actively developing this structural change, and unless you know exactly what nuanced secondary clues to hunt for, you might just sign off on that printout as totally normal. But why is it so elusive?
Now, you might be sitting there thinking, hey, no big deal. We'll just catch it on an echo, right? Actually, scratch that. Transthoracic echocardiograms are surprisingly less sensitive when it comes to the right ventricle, because anatomically it sits right tucked behind the sternum, making it notoriously difficult to get a clear visual with your standard ultrasound windows. And because of that imaging blind spot, mastering the ECG isn't just some academic exercise. It's absolutely crucial. It becomes our ultimate, indispensable investigative tool. To really grasp the ECG changes, we have to look at the physical reality of the heart itself. It's basically a classic David versus Goliath scenario. Normally, the massive left ventricle is our Goliath. It's just so much larger and thicker than the right. Because of all that muscle mass, the normal QRS complex on an ECG is completely dominated by the left ventricle's electrical vectors. The smaller right ventricle, our David, generates normal electrical vectors that just get completely overshadowed by the big guy. Here is our roadmap for this explainer. First, we'll uncover the hidden right ventricle. Then, we'll review common causes of RVH, spot the specific ECG clues, explain right axis deviation, and finally, do a head-to-head comparison of RVH and LVH. Starting with Section 1, the hidden right ventricle. Let's take a closer look at why this side of the heart is so good at hiding in plain sight. So, because the left ventricle is such an electrical giant, right ventricular hypertrophy has to be severe to actually shift those visible electrical vectors on your readout. Think about it. For the right ventricle's electrical signals to actually punch through all the overwhelming noise of a normal left ventricle, it has to really bulk up. The hypertrophy must be absolutely pronounced before that QRS complex even begins to morph. Moving to Section 2, Common Causes of RVH. Okay, let's dive into this and look at the underlying etiology to see what exactly forces the right ventricle to bulk up in the first place. You know the basics. The right ventricle pumps blood to the lungs. So it makes sense that anything increasing pulmonary resistance is going to force that muscle to work overtime and grow thicker. Chronic lung disease is a huge culprit here. We also see it with congenital heart issues, things like transposition of the great arteries, pulmonary valve stenosis, and atrial or ventricular septal defects. Oh, and don't forget tricuspid valve regurgitation. Keeping this clinical context in the back of your mind is key before we start analyzing the squiggly lines. Section 3. Spotting the ECG clues. Now we're getting to the core of the explainer. This is where things get really fascinating, as we decode the waves and hunt for the specific electrical fingerprints RVH leaves behind. Now, what's really interesting about this slide is that bottom row. Look at the illustration of the heart there. Notice that heavy black arrow pointing down and to the right? In RVH, the hypertrophied right ventricle gains so much muscle mass that it physically pulls the overall electrical vector toward the right side of the chest. It's literally an electrical tug-of-war, and for once, David is actually winning. Let's zoom in on the V1 and V2 columns. Those are your right-sided chest leads. Since that electrical vector is now actively pulling toward the right ventricle, the R wave in these leads becomes totally dominant. So instead of seeing a small R and a deep S, the R wave gets larger than the S wave. You're also going to notice the R wave peak time is prolonged, usually stretching out to around 35 to 55 milliseconds. But, and this is a big but, the overall QRS duration typically stays under 120 milliseconds, assuming there isn't another underlying issue going on. All right, stop right here. I need to issue a massive warning. This is a diagnostic trap that catches so many folks out. In leads V1 and V2, RVH can occasionally throw up an RSR prime pattern. Visually, it looks incredibly similar to a right bundle branch block, or RBBB, but it is absolutely not the same thing. You've got to look closely at your QRS duration. If it's under 120 milliseconds, but you're still seeing that classic bunny ear pattern with right-sided dominance, well, you need to bump RVH right up to the top of your differential.
On to Section 4, Right Axis Deviation. Let's zoom out for a second to look at the broader 12-lead context. The crucial point to remember here is that those dominant R waves in V1 aren't working alone. You'll often spot discordant ST segment changes, which are essentially strain patterns in those exact same right-sided leads, V1 through V3. Meanwhile, over on your left-sided leads like V5, V6, lead I, and AVL, you'll see smaller R waves than you'd normally expect. You might even catch an entirely opposite R wave progression across the precordium. But what's the absolute most important secondary sign? The electrical axis is practically always shifted to the right. Seriously, a right axis deviation is considered almost mandatory to confirm this diagnosis.
Real quick, aside from the axis deviation, there are two other classic companions that love to show up with RVH. Always keep your eyes peeled for the S1, S2, S3 pattern. That's when you see S waves hanging out in leads I, 2, and 3. And second is P pulmonale. That indicates right atrial enlargement, which makes total sense, right? The right atrium often dilates because it's struggling to push blood into a stiff, bolted-up right ventricle. Section 5. Comparing RVH with LVH. We are building up to the climax here with the ultimate visual pattern recognition test. Let's put these two head-to-head.
And this brilliantly illustrates the difference. Over on the left, we've got left ventricular hypertrophy, and on the right, right ventricular hypertrophy. I want you to look closely at V1 and V2 in both examples. In LVH, that massive left ventricle is violently pulling electricity away from the right-sided leads, giving us these incredibly deep, plunging S waves. But jump over to the RVH example on the right, the vector is pulling hard toward the right, leaving us with those towering, dominant, spiked R waves in V1 and V2. Seeing them side by side like this, the difference is just striking.
Now shift your focus to the V5 and V6 leads. It is a perfect mirrored effect. With LVH, the left-sided leads show massive R waves because all that electricity is rushing right toward them. But with RVH, those same left-sided leads show deep S waves because the electrical vector is being pulled completely away over toward that hypertrophied right ventricle. It's just a beautiful demonstration of how the electrical vector completely flips depending on which ventricle is throwing its weight around. So we return to where we started. The right ventricle is a true master of disguise, happily hiding in the shadow of the massive left ventricle until the hypertrophy gets so severe it just forces its way onto the ECG strip. But guess what? Now you know its secrets. You know to hunt for that dominant R wave in V1, the prolonged peak time, the mandatory right axis deviation, and those sneaky RSR prime mimic patterns. Which leaves me with one final thought for you. If moderate RVH can hide so easily in plain sight, what critical clues might you be missing the very next time you quickly scan a quote-unquote normal ECG? Challenge yourself on your next shift to look beyond the obvious and go hunting for those hidden vectors. Thanks for joining us for this explainer.